This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. We're going to talk about compassionate use drugs, and we're going to explain to you what they are. We've got Dr. Micha Koentz with us, who's a pharmacy supervisor at Cook Children's Medical Center. Dr. Koentz, welcome to the show.
Thank you.
Can you explain to our listeners what compassionate use drugs are and how they help patients at Cook Children's Medical Center?
Sure. So really, there's three main ways to get a hold of a drug. So the one you're probably most familiar with is commercially available, FDA-approved drugs. So your doctor writes a prescription and you can get it filled at Walgreens. That's the most common way. Second, you can get a drug via a clinical trial. So if you are on a research protocol and we're investigating a drug and we're collecting your data to try to get it FDA approved, you can also get drugs on clinical trials. There's this third route to get drug called compassionate use. So if you can't get it from your Walgreens, insurance won't cover it, you're not eligible for a clinical trial, you can try compassionate use. And so that is basically when the drug company will agree to give you access to their drug via compassionate use in order to try and treat your condition off-label, really, and outside of a clinical trial.
Are compassionate use drugs used primarily as an inpatient, or can they also be used on an outpatient treatment plan?
Good question. I would say most of our compassionate use drugs are given to patients in the outpatient setting. So most of our drugs are oral chemotherapy agents, so we'll give them, a 30-day supply and they're allowed to go home and take it outpatient. But they do start sometimes in the hospital because they're pretty sick. But we do most of our compassionate use drugs outpatient outside of the hospital.
Is a compassionate use drug generally where the insurance will not cover it or the people do not have the funds to pay for it? Or is there other reasons you have compassionate use drugs?
So most of the time because the insurance won't cover it or because it's just not available yet. It's only in clinical trials. So in our world in pediatrics, it's really hard to have chemotherapy approved in pediatrics. Most of drugs that are approved are in the adult world. They really don't have the data or dosing formulations available for kiddos yet. So a lot of the time we have obtained these drugs. It's used in the adult world, but we're trying to find the perfect fit in the pediatric world. So a lot of times patients that are kids are not able to get those drugs because it's in a form they can't take, like a pill they can't swallow, or insurance won't approve it and pay for it because it's just not approved in pediatric cancer.
That's very interesting. So what is the process at Cook Children's that you go through to help these patients get the medication?
It's most easiest and convenient if we can get them a commercially available drug. Insurance approves it, it's on our shelf, it's ready to give them. We also love clinical trials in pediatrics because we want to collect data and we want to get these drugs FDA approved because they have so little options. So those are definitely our first two routes that we would love to get them the drug that way. But if we do have a patient with a certain type of cancer with a certain target or mutation, and there's a drug out there that could work, and they're not eligible for a clinical trial, we don't have that trial open here at Cook, insurance won't pay for it, we'll then call up the drug company like Novartis or Pfizer, whoever the drug company is that makes the drug, and we really plead our case. Hey, we have this patient, they have this mutation that your drug targets, we want to trial your drug in this patient, they are out of options, they've relapsed 3 times, please give us a shot at your drug, we really think they'd be a good candidate. So really the first and hardest step is to call the drug company and convince them to give you free drug, which is not always a home run. We definitely do get denied there at step 1. But calling the drug company and basically pleading your case for why your patient deserves a shot at their drug is the first step.
To help our listeners really comprehend compassionate drug and use and we don't want to violate any privacy. Could you give a real-life example of how compassionate drug use really helped a patient?
Sure. We have one patient I'm allowed to talk about. His name is Xander. He had multiple relapsed refractory Wilms tumor, kept coming back. He has gone through lots of chemo and surgeries, came back again. So basically his whole body was full of tumors, and we thought we'd give it one more shot. So he went to surgery. Surgeon removed as many tumors as he could find. We then radiated the areas. We wanted to give him something after his surgery and radiation to hopefully help keep the cancer at bay and not come back, because he's gone through all of these other chemotherapies. So we were able to contact a drug company and get him on a compassionate use drug that insurance would not pay for. He was a kiddo, so he needed a smaller dose, and they only had pills available. So we had to dissolve the pills and make it into an oral solution so he could drink it. And the company gave us access to their drug. He has been taking it now for almost 2 years, and he has not had any of his cancer come back. He's had stable disease, which is amazing because he is used to, having the cancer come back, being refractory, trying IV chemo, having lots of surgeries and radiation. So now he's this normal average kid playing and being healthy and is taking an oral chemo, and knock on wood, his scans have been stable and he's doing great today. So we've had about 2 years with him on this drug with no cancer coming back.
That's remarkable. What a great story, and what a great example of a compassionate use drug. Cook Children's obviously is a children's hospital. You treat pediatric patients. Is a compassionate use program at Cook different than at other hospitals?
So I would say our process that we do this at Cook is unique because I have a pharmacy team. It's myself, a pharmacist, one other pharmacist, and a pharmacy technician. So we have this team of 3 that really handle the compassionate use drugs. So usually the doctor will identify what drug they want to go after, but we are in charge of contacting the drug company, getting the approval from them. We will also have to get FDA approval. So even though we're doing this compassionate use, the Food and Drug Administration has to also bless this process. So we will write up our treatment plan, get the FDA approval. We'll then submit to our IRB, or our Institutional Review Board, and that's really the ethics committee at the hospital, and they make sure the patient benefit outweighs the risk. So we'll submit to our IRB. We'll then hopefully get all of those approvals. We'll then get the drug shipped to us, and then we can treat the patient. So I would say we're different than other hospitals in that our pharmacy research team really handles all of those steps. Instead of having a lot of different people involved, we kind of streamline the process and get it done pretty quickly and efficiently.
So that sounds like quite a process you have to go through. Is it a long, drawn-out process, or do you do it quickly and efficiently?
I would say every step usually takes a couple of days to hear back and to have people review it and approve. But I would say on average, the time that we contact the drug company to ask if we can use their drug from the time that the drug goes into the patient's mouth probably takes about 2 weeks or less.
You're listening to The Human Side of Healthcare, where medicine and helping humanity intersect. This is Dr. Micha Koentz from Cook Children's Medical Center with more on this program to help kids with cancer get the medications they need for life. Next.
This is The Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're continuing our conversation with Dr. Micha Koentz, a pharmacy supervisor at Cook Children's Medical Center, about this compassionate use of pharmaceuticals, particularly in this case for kids with cancer. This and all of our interviews are available on our podcast and on our YouTube channel, The Human Side of Healthcare. Steve?
So let me ask you this, and this is kind of a crazy question, but let's assume you have a patient that's got an FDA-approved medication that really works, and then there's a generic that comes out, but the generic doesn't have the same efficacy, but the insurance company says you have to use the generic. If you then use the brand name drug, would that be a compassionate use?
Good question. It's always worth it if the patient wants to be on it and the insurance won't cover it, and they have been on it and it has been working. it's always worth, I never say no. I always ask for permission because there's nothing you're not allowed to ask. So I would always just call up the drug company and explain the situation and try to get the patient to be able to get the drug that's been working for them and that they prefer.
Micha, you're so passionate about your work. You're helping kids and families with cancer. That has got to be so fulfilling.
Oh, yes. I do have to pay the bill, so I have to get paid but I would almost do this job for free. I love it so much. I'm very passionate about it. In general, childhood cancer is pretty rare, even though that's what I see all day, every day in the real world. There's really not a whole lot of funding and research in pediatrics with cancer. Most drug companies focus on the adult world because that's where they're going to get more return, more bang for their buck. So when we have these patients that are kids and they've relapsed and there's something out there that might work, but we don't know the formulation, it's just really good to be an advocate for them and try to obtain a drug that they could get if they were in the adult world, and let us try it in them, because the more that we can try drugs and expand our knowledge and keep continuing research in these avenues, the more stuff that we can get approved for these kiddos that insurance will pay for. Compassionate use is not something that you're going to do first line on initial diagnosis. It's something that you do when you've run out of options and you can't get them a drug anyway else. So with this compassionate use program, we really can add days and weeks and months and years to a patient's life, giving them a drug that they would otherwise not have even had access to. So it's such a cool process, and it's free. Patients are not paying for this drug.
I'm glad that you explained that in your answer, that it's free. And I'm also glad that you say it's not the first line. It's not like you're going to the hospital and you're experimenting with drugs. As you said, you have an institutional review board, and you make sure ethically it's the right thing to do for the patient. Thomas, do you have any questions?
Is this only related to chemotherapy?
Good question. So we actually have two pharmacists, myself and another pharmacist, Jamie, and I do the oncology kids. So all the kids with cancer, a solid tumor, or a blood cancer, and Jamie is in charge of the non-oncology compassionate use. So recently she's been helping some patients with Crohn's disease or ulcerative colitis get some access to drugs compassionate use. So it's not just chemotherapy, it's definitely all disease states.
So that was my next question. How many people know about this, and then how many people go for this?
I would say it's really unknown. I'm a pharmacist. I went to pharmacy school, and I did not even know about this avenue of obtaining drug until the past couple of years. I mean, who knew that you could call up a drug company and plead your case and try to get drug for free? I did not know that was an option. They did not teach me that in pharmacy school. But I think that once we've opened the door at our institution, once we did our first one, it was successful. We kind of got the word out. Now all of our doctors will come to us and say, hey, can you get this compassionate use? Hey. So at our institution, it's pretty well known because we've done it for a lot of different specialties and physicians. I've actually done a couple of talks nationwide of how this process works and how they can try it if they've run out of options. But I would say, overall, I'd say it's pretty unknown, that it's a lot of steps and it's a lot of paperwork. So it is a lot of work for an institution to do. But if you have a dedicated team who's good at it and can focus on it and streamline it, it really works out well.
So then how many people take advantage of it? Once it comes up, is it like, oh, yes, please, please, please? Or is it, well, let's think about this?
Last year in 2021, I think my team did 9 compassionate uses over the course of a year. And now in 2022, we've done 9 compassionate uses so far this year. So every year we are definitely revving up how much compassionate use we are doing. It's getting more and more popular, and we're doing more and more each year.
How big is the child drug pharmaceutical pipeline? Is there a lot of development for pediatric drugs, or is it a fairly narrow pipeline and you see things occasionally come finally pass FDA?
Super narrow. I mean, I would say as far as development in pediatrics, it's very slim to none. A lot of times we are getting adult drugs that we think could work in our kids, and we're trying to extrapolate those to our kids. It's really rare that you're going to have brand new, made-for-kid drugs. I would say in the adult world, they have a different history, different life. They have these cancers that have certain mutations or targets, and we find that about 20% of pediatrics are showing those same targets. So about what's out there in the adult world, if we have a patient with that target, we can grab an adult drug and try to use it in our kids. But really, it's pretty rare that you have new and exciting drugs in pediatrics. It's just rare, and it's hard to get a lot of patients to collect data and hard to have drug companies invest because they're not going to get a whole lot of bang for their buck in return.
What are some of the other medications that a child would be on for a prolonged period of time?
There is a drug class called tyrosine kinase inhibitors, or it's an oral chemotherapy. So they'll target different things within a tumor. So these oral agents, they will, target a certain point or mutation in the cancer. And so they'll be on those really until they progress or relapse. So they're kind of on them for life, or at least for several years.
So mental health drugs, especially teenagers, is that something that's prolific now? And is that one of the areas where kids do possibly take drugs for an extended time?
That's definitely a category in pediatrics that we treat, but compassionate use-wise, that's not something that we personally have gone after or trialed in our kids.
When you do clinical trials, do you do double-blinded? For example, let's assume it's kind of, as you say, last resort, you want to try a clinical trial. Are you given the actual medication, or are you also given placebos?
There are certain trials we do placebos for, but there always will get the standard of care. So if you have a new patient with leukemia, you'll give them standard of care drug, what they would normally get no matter what, but then we'll give them a placebo or an extra drug in this other arm to see if standard of care works best, what we normally would do, or if this extra drug would work well, it works better or worse. So, but whenever we do compassionate use, though, when it's end of line, we definitely don't do placebos there. They're getting actual drug from the drug company.
You've made it clear this is a collaborative, joint effort of a lot of people that contribute to this. What role specifically does the pharmacist play? Can you go into more depth on that?
Sure. So whenever we get them a compassionate use drug, we are aware of side effects that exist. Usually they are side effects that happen in the adult world, so we can usually extrapolate those to the kids. So you might see, high blood pressure, low blood counts. So we will counsel them on what side effects to expect. But also, we are experimenting. These aren't FDA-approved drugs. So we really follow up with the kids and say, hey, if anything out of the blue happens, please call us, let us know. We want to know what happens with you taking this drug. We look at other drugs they have on their profile. So other drugs they are taking, we'll look at side effects. We counsel them on what to do if they vomit a dose. We have a lot of, nauseous children. So if they vomit a dose, do they retake it? Counsel them on, do you take it with water, empty stomach, with food? Take it at the same time each day usually. So we really are counseling them on how to take the drug, when to call us, what to expect.
And then I would imagine that the process that you described of going through all of the channels at Cook that you mentioned keeps this from being abused from a patient standpoint or some kind of take advantage of standpoint?
Yes, with all of the bodies in place to help regulate this, it's definitely has to be the perfect situation in order to get the drug approved. Really, the drug company is not going to give you, access to their drug unless it's a case like this. Because if you can get it commercially at Walgreens, they're going to want you to do that route first because they're going to get paid for it, and it's, FDA approved for that. But with all of the ropes and paperwork and everything we have to go through, it's definitely going to be, it's hard to get it. We've only done, 9 last year and 9 this year. So it's definitely not something that happens a lot. It's hopefully last resort, and we've ran out of options.
And as far as the scope of this, I would imagine these are all very expensive drugs.
Oh, yes. I mean, you're talking tens of thousands of dollars for a 30-day supply. So nothing that anyone is going to be able to pay cash for, at Walgreens. It's $100,000 a month maybe for a 30-day supply. So it's wild. These drugs are so expensive.
We've been listening to Dr. Micha Koentz from Cook Children's Medical Center about this compassionate program, Compassionate Drugs for Kids with Cancer. When we come back, we're going to also talk about an issue that affects kids and adults. It's scoliosis. Spinal surgeon Dr. Jeffrey Phelps next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're going to be talking about a spinal issue that impacts children and adults. Delighted that we've got Dr. Jeffrey Phelps, who's the Medical Director of Spine Services at Medical City North Hills, with us today. Dr. Phelps, welcome to the show.
Thank you very much for having me. I'm happy to be here.
Dr. Phelps, could you explain what scoliosis is?
Absolutely. So scoliosis is basically defined as an abnormal curve of the spine that usually goes lateral. And lateral means to the right or to the left. And there's two general populations of people that we see that get scoliosis. So one group is juvenile scoliosis. And so that's the younger people that usually get screened. And I think we're familiar with that because I think all of us in public school were screened, when we were 10, 11, and 12. And that's the first patient group that we typically see with scoliosis. The other group of scoliosis, and it's one that we probably see quite a bit more often, is adult-onset scoliosis. And that's a curvature that's caused generally by arthritis of the spine. And we have fancy words like degenerative disc disease and things like that describe that. But more or less, it's because the bones and the joints of the spine start to get worn down, and you start to get a curve because the bones just aren't held in place like they should be.
You've brought up two really good, distinct discussions. So let's talk first about the pediatric, if you will. Are there ways that we can prevent scoliosis in our children?
That's a really great question, and the answer is no. And the reason is because the main cause of scoliosis in children is unknown. So we call it idiopathic juvenile scoliosis. And doctors use the word idiopathic to mean we just don't understand. So the main cause of most scoliosis in children is not really known. Now, there are causes that we do know that can cause scoliosis, things like cerebral palsy or certain sort of bone defects in kids. But again, the majority we just don't understand. So that brings us to early detection, and that's why that's very, very important. And so when we're looking and we're screening for scoliosis, things that parents can kind of be aware of is that they might see that their child has a shoulder blade that's higher than another, or that their hip looks a little bit off kilter, or their ribs might be a little bit more prominent. And so it's important just if we start to see sort of these things that we go see a healthcare professional or a spine surgeon. Not that they need spine surgery, but it's important to recognize scoliosis early, because a lot of times you can treat it and you can treat it without surgery. And in fact, actually, most of the times you can just observe it, which means we don't even have to do bracing. We don't have to do any of those things. We just have to watch it to make sure it doesn't get worse.
Along those same lines, then, if a parent as a child experienced scoliosis, is there a likelihood their children might also?
Again, we think there probably is a genetic component to it, but again, we don't have that very well defined. So just because if you had scoliosis, whether it was mild or severe, does not mean that your child will absolutely get it. Now, I think most people would agree that the risk of maybe having a child that does have a curve is going to be higher with a parent that had scoliosis. But again, we still just don't really understand the cause of most of the juvenile scoliosis, or really the genetic markers that are going to predispose people to scoliosis.
Going to pivot a little bit now and talk about the second group you mentioned, the adults. And I realized that maybe as children they did not have scoliosis, but as they got older, as you mentioned, with arthritis, they may have developed it. Are there ways for adults to prevent scoliosis?
I think the best way to prevent scoliosis in an adult is really just keeping your spine in shape, right? So I'm going to go and generalize this. How do you keep your back, your neck, your spine, everything in shape and prevent you having to go see a doctor for any sort of pains or aches or anything? And that's twofold. One is it's maintaining a healthy weight. That's very important. The second thing, and it's probably more important, is you keep a strong core. So a core means that we want to have a very strong belly and very strong back muscles, because what that does is that supports our spine and helps prevent it from going down this road of getting a lot of degenerative changes. Because if you remember the second group of people, the reason they start to get scoliosis is because they start getting severe arthritis in their spine. And we know that if you keep a healthy weight and you keep a very strong core, the chances of you developing arthritis in your spine is less. And if you already have arthritis in your back, or you're starting to develop a curve, we know that keeping a strong core is going to help decrease the pain and is going to help decrease the chances of your curve getting worse.
You're listening to The Human Side of Healthcare, where we're talking with Dr. Jeffrey Phelps. He's the Director of Spine Surgical Services at Medical City North Hills, and we're talking about scoliosis.
Is how you sleep at night and the type of mattress you have, does that impact that strong core?
So that's a great question, and that's probably a question I get every day in clinic. And the answer is, there has been no data to show that, let's say, a hard mattress or a soft mattress really makes any difference in terms of your spine, in terms of getting arthritis or not getting arthritis, or whether or not you already have some back pain. Meaning, some people that come see me who already have back pain, they're going to be more comfortable in a softer mattress, and there's other people that are going to be more comfortable with a harder mattress. And just to add on, the same thing kind of goes with pillows as well for people who have neck pain. There's never been a real clear connection between hard or soft mattresses. It's whatever makes you comfortable. It's whatever lets you rest well at night, because that's obviously important and it helps with your well-being. It all really comes down to is maintaining a nice, strong core and keeping that core strong your entire life, meaning, it's 15 minutes a day. Most core exercises do not require equipment or fancy gym memberships. They're things that you can do and look up on the internet and do 15 minutes a night before you go to bed. We know that makes a huge difference.
For our parents out there, what are your words of wisdom? Obviously, hopefully they're seeing their pediatrician regularly. They're looking for some of the signs and symptoms you mentioned. But do most pediatricians check for scoliosis, number one? And then number two, if you do get a diagnosis, what are some of the implications you could help give encouragement to parents?
Most pediatricians do screening. So as I mentioned, they still do, certainly in my school district that my children go to, they still do scoliosis screening. And a simple test that you can do, and this is what they do at the school, is the simplest way is to have your child face away from you, lean over and let their arms just dangle right above their feet. And you're simply looking to see if one rib cage is slightly higher than the others, or you can see a curvature of the spine going down the middle of their back. And that's something that certainly you can simply do at home. And again, if you have a concern, you can certainly go see your pediatrician or your local spine doctor just to get it looked at. So the best encouragement I have is the vast majority don't need any treatment at all. It's important to recognize someone that might have a curve, simply so that you can get an x-ray, you can measure what that child has in terms of a curve, and then you just follow it. And the majority of kids don't necessarily progress at all. For those that do progress, the vast majority, again, of that group can be treated with bracing. It's not very common to progress on to surgical intervention for children when you look at the whole picture of all the kids that have some degree of curve. So the vast majority are not going to be treated with anything invasive or anything harsh.
Many children, as you know, we refer to in layman's terms as growth spurts. So if you're a parent and have a child, how frequently should they be checked for scoliosis?
Most of the recommendations start at age 10, and probably, honestly, once a year is enough. You're going to see it more commonly in girls than you are going to see in boys, but I think that once a year is certainly enough. And most kids that age are getting immunization, so they are seeing their pediatricians. So it's something that they can simply ask their pediatrician to take a look at and make it sure that it's part of their well-child visit. Because sometimes parents may be a little nervous about looking themselves, and they want to have someone that does look at a lot of backs every day or every week. And so that's where a pediatrician, or again, if you're concerned, a spine doctor or a spine surgeon, just because we're spine surgeons does not mean that you're going to have a surgery. And that's sort of a misconception, meaning, I think 98% of people that come see us never even have a surgery. We see people for all sorts of different problems, including scoliosis, but the vast majority of people, both adult and juvenile, get treated with non-invasive, non-surgical treatments, which is enough to carry them through and make them happy.
Is scoliosis more prevalent in boys or girls?
The vast majority of scoliosis in children is that word that we say it's idiopathic. So we're not exactly entirely sure why most children get scoliosis. Again, we know that certain things can cause it, such as cerebral palsy, and I mentioned some certain types of bone issues where the bone has fused before they're even born, and so sometimes it can make the bone grow abnormally. But the vast majority is we don't know, and that's what a lot of research is kind of obviously being done in terms of why do these kids get it? Are there genetic markers that we can see prior so we can start to identify these kids early on? That's obviously a huge topic of research.
You're listening to Dr. Jeffrey Phelps from Medical City North Hills talking about scoliosis, a disease that affects children and adults, particularly if we don't strengthen that core as we age. This interview and all of our interviews are on our podcast and YouTube channel, The Human Side of Healthcare. More ways to prevent our spine from curving when we come back.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing our conversation about scoliosis, a disease that affects children and adults, kind of both ends of the time spectrum of life. Our guest again is Dr. Jeffrey Phelps, the Director of Spine Services at Medical City North Hills.
On scoliosis with the non-invasive, what are some of those treatments? Are there special braces or exercise or all of the above?
It depends a little bit more on the group. So usually juvenile scoliosis is the main treatment is observation, like I mentioned. And so if a curve goes past a certain level and you see it continue to progress, then the next step is you go into bracing. And the braces have changed over the years and have gotten better and certainly more comfortable than they were decades ago. Most kids that go into bracing stay in bracing until they're sort of mid-adolescence, and then they're able to come out of it because, as you said, once you kind of get through puberty, you really stop that growth cycle and you don't see the progression nearly as much. In severe cases, and we're talking cases that are over 50-degree curve, which is a severe curve, those are the cases where you're probably going to be looking at surgery. What's unique about juvenile scoliosis is it's non-painful. Typically, the vast majority of scoliosis in children does not hurt them. You find it because you see a curve, or the child notices, again, their shoulders are a little bit at a different height, or their hips are kicked out. Contrast that to adult scoliosis, because we know that adult scoliosis is caused by arthritis, and so we know that arthritis is painful. We have cartilage in our bones and in the discs between the bones of our back that are just like the cartilage in your knee or your hip. And so as we get older, that starts to degrade and that starts to wear down. And that's what ends up causing the scoliosis.
In juveniles, are there other health issues that could result from scoliosis, and likewise the same for adults?
Sure. So when we look at juvenile scoliosis, one of the things you want to make sure is that the scoliosis is idiopathic, meaning it's caused by something we just don't know. The thing we worry about is if a curve gets so large, you can actually start to decrease the amount of space your lungs have. And so in severe cases of scoliosis, you'll actually see kids that have difficulty breathing because their lungs don't have the area to expand because the curve is so much, it causes their chest cavity to decrease in size. Now that's severe, right? And so generally, and certainly in the United States, we're able to identify kids before they get to that stage, but that's a concern. Really with adults, the main issue is their pain problem. And so they start to develop low back pain, mid back pain. Those are the things that generally drive people into the office. Now, in severe cases, these aren't the normals. These are the people that have severe cases that we see, but they're not nearly as frequent as mild cases. But in severe cases, again, you can get some pulmonary function problems, meaning the lungs don't have space to expand. The other thing we start seeing in adults, because we start getting bone spurs and bulging discs, is you start getting what most people are going to call sciatica, right? They're going to start getting leg pain, and they're also going to get something that we call neurogenic claudication, and that's a fancy term meaning you're not able to walk really far. And you'll see people at the grocery store, they have shopping carts, and they're leaning over the shopping cart because they're just not able to walk very far. And that happens because the canal where all your nerves travel in your low back starts to get pinched in. And that word we call is stenosis. And so scoliosis can cause that pinching of that canal, which really starts limiting the ability for people to really walk any sort of long distance without having to sit down, take a 5-minute break, and sort of reset.
Dr. Phelps, I have a friend who in her 60s started to develop adult scoliosis. And for years, she worked in a restaurant, and they made soup by the buckets. So she was often throwing around these big bags of whatever went into the soup. She gets into her 60s, here comes the curvature. So I was thinking, after what you were saying, is any repetitive exercise, like even going to the gym or anything we do on a repetitive basis, could that help contribute to this?
I think things like that can affect your back. I think the important thing to remember is, I see a lot of people that have pretty significant back changes, degenerative changes, herniated discs, that often occur because they weren't doing anything necessarily really heavy, in terms of lifting or bending. For the people that do that sort of thing, it's always important to do those tasks, whether it's lifting or twisting, following the rules that we all sort of know we're supposed to follow, but we never do, right? Meaning we should always lift up heavy objects with our legs. We shouldn't lean over to pick up things. I think repetitive twisting obviously is a problem, and I see that a lot with people who have maybe like a machinist job where they're having to twist from one workstation to another. And that kind of falls back down to, and again, I keep talking about it, but having a strong core is going to help protect your back, because we're not able always to choose exactly what we do at work or how or the tasks that we have to do at work, but we have control over how we can do those tasks, right? And we have control over the health of our back when we do go home. So again, I think it's important to remember the rules that we're supposed to follow, meaning, again, always lift with your legs, and then always keep your back as healthy as possible. And I think those are the most important things.
Does scoliosis continue to progress, kind of like, let's say, Alzheimer's? You get on the train and you never get off, or does it go to a certain point and then it can stop?
The answer is both, and that's sort of why it's important to, A, identify it, and then, B, continue to follow it. So we talk about the juvenile subset, right, which means that we should identify it early, and we do want to watch it for a number of years until generally the child goes through adolescence and kind of past puberty. And the same thing with adults. I've seen relatively small curves in an adult progress over the next few years, and I've seen, a moderate curve not move at all. With adults, it's more about treating a lot of the symptoms that typically come along with it in terms of the pain and if they're having a pinched nerve or something along those lines. Most adults are relatively okay having a curve to their back in their later years. They're more interested in being comfortable, right? Not being in pain. And so that's, in that group of patients, that's what we're really focusing on. Although it is important to keep following them so that it doesn't progress to a point where it starts to cause problems.
And then if you get that, does it ultimately also affect your hips and even your knees?
Absolutely. So what a lot of people will come in and complain about is, again, they'll say their hips are crooked, and what they're looking at is they're seeing that one of their hip bones, and it's really the pelvic brim, right? So we have that little bone on our side of our pelvis that we can feel, and one is tilted a little bit higher than the others. And a lot of people will start walking differently, right? Because they start having these changes and they start having a little bit of a tilt in their hip, or they're hurting on one side and not the other. And so when you start changing how you walk, which doctors call a gait disturbance, you can start putting pressure on knees and ankles in a different way than you have your entire life. And so I'll have people come in and say, my knees really starting to bother me, or my hips are starting to bother me. And something interesting that you can even look at is you can look at the bottom of people's shoes, because the tread on the shoes will start to wear differently. If they're walking a little bit differently, they're not walking evenly, you'll see maybe the left shoe has all the tread worn down at the toes, and the right side is completely normal. And so you know that they're not walking with a steady, normal gait, that something's changed.
That's exactly what happened to my friend. Gait change, and now she has titanium everywhere below the waist. It's like she has had quite a few procedures.
Right. And so when it gets severe, that's generally what you end up having to do is you straighten it up and you open up the space for the nerves. The good news is everyone knows that spine surgery had certainly a bad rap, and I'm the first one to tell you that spine surgery is the last thing you ever want to do. And this is coming from a man that is a spine surgeon. The good news is that if you do progress to that level that, well, now you probably really need to consider spine surgery, what we're doing now is far and away better, simpler, safer, less painful than what we were doing even when I started almost 17 years ago. And I can't imagine that as we progress and as we learn more, that things are just continually get better every few years. We're learning new things and learning better techniques, and so it's a different world than it certainly was before.
So strengthen that core. That's the bottom line.
That is the take-home message of today.
We've been talking to Dr. Jeffrey Phelps from Medical City North Hills about scoliosis. This interview and all of our interviews are on our podcast, The Human Side of Healthcare, wherever you get podcasts and on YouTube. Steve?
Thanks, Thomas. What a great show. And to our listeners, we hope that you will join us next week for The Human Side of Healthcare.